and we have interpreters who will do absolutely their best to interpret all the presentations and all the questions and answer sessions for you from English. The webinar is conducted in English to the language that you choose. So please use this function if this will make your learning experience better. Another function that I would like to remind you about is the chat function. The icon for that function is shown on the screen. And when you press that button on the right, or sometimes below or above, a window opens, and this is where you can introduce yourself and you can make comments about the webinar. But this is not the place where you ask questions and have your questions answered. For that, Zoom has a separate feature called Q&A. So please pay attention to this slide. It shows the Q&A button. When you press it, you can type your question, and the question will appear on the screen, and it will be kept there, and we will either answer it live or chat or type the answer in this session. Okay, so these are the 3 important functions that will help you enjoy today's webinar. Now, apart from today's webinar, we've done quite a bit of work over the past years. And if you go to your browser and you type IFC IQ Health, this is where you can have a summary of all our resources. We do have a web page that has information about healthcare quality. We do have different resources, and we have a YouTube channel where you can watch this webinar live in case you have to step out or you have to attend to your patients or you have another important meeting. Then you can return and watch this webinar on YouTube as a recording after the webinar. We do have a community of practice on Facebook, and you can join it, and you can learn and exchange opinions with other professionals. We do have materials on LinkedIn. We do have recordings of our previous webinars. We've got 32 so far. And we do have free online self-paced trainings in healthcare quality. This has been our most wanted feature. And this is how you do it. You type WBGOLC, World Bank Group, Open Learning Campus, and you have this link appearing, and it takes you to the page where you register, and you can take one of our 10 trainings so far. The trainings are in English, but we are adding trainings in French and in Arabic soon. And what's most important, for each of those trainings, upon completing the questions, a test at the end of the training, you receive a certificate awarded to your name. So when you register, please be sure to put your name as you want it to appear on the certificate. Okay, so for this webinar, what we want to, in exchange for all that, we just want you to fill out the survey on exit that will take you less than 3 minutes, and basically 5 questions or so. You let us know how we did. You let us know what's important for you, what you would like to see in our further webinars, or just send an email to us in response to our invitation, and let us know everything that we can improve or that we should keep up. Thank you very much. This is my presentation. I'm done. And
Thank you very much, Natalia. Yeah, you wanted to say something?
Yes, I wanted to pass the floor to you, Julia.
Thanks so much. So hello, everyone. Welcome to IFC series of webinars on patient safety and quality. Happy New Year. I hope all of you enjoyed the holidays and had a great time. And today we're going to discuss antibiotics. Antibiotics actually is one of the most controversial type of medications because they can do a lot of good if used properly, but also there is a lot of potential harm they can make if misused. So that's why today we are going to discuss how to make the best benefit of it and how to avoid harm from it. And our speakers today hopefully will help you answer this question and structure the work with antibiotics in your facility. So work with antibiotics as work with any other type of medications is always a journey. It's not a destination. And about the journey, today is going to tell you our first speaker, Jose Luis Ramos from Honduras Medical Center. So Jose Luis, the floor is yours.
Hi, Jose Luis, you are muted. Can you unmute?
Yeah, thank you, Manuel. Hi, good morning, everybody. Thank you, Julia, for the presentation. I don't, do you all see the presentation?
Yes, we do.
Okay,
Yes, we can.
perfect. Thank you. Well, hi, as Julia introduced me, my name is Jose Ramos. I'm the quality manager of the Honduras Medical Center. This is a private hospital in Honduras, and I'm going to talk to you about our experience, our journey in the inception of antibiotic regulation at Honduras Medical Center. Okay, first, to give you some context of the hospital, Honduras Medical Center is a private hospital located in the city of Tegucigalpa with a 20-year history in the country's healthcare sector. So this, actually 2023 was our 20-year anniversary. So we're going this year to our 21st anniversary, actually. This hospital is recognized as one of the top healthcare facilities in Honduras nationally. So it's one of the reference hospitals in the private sector. And we also get like a lot of support from the public sector, from getting patients from them, so we can like support them in these terms. Our hospital has 44 beds and offers various high complexity services and specialties. And in spite of that, actually, the country, the problem we have is that Honduras lacks of a mandated antimicrobial stewardship program, and this contributes to the indiscriminate use of antibiotics. So here in Honduras, we don't have any legislation, any regulation, any law that forbids or regulates the use of antibiotics in the country. So this is like a big issue, and we have seen it throughout the years, all the evolution that this has like given us. Some quick context of the hospital: we have some services: emergency lab, radiology, physical therapy, pediatrics, maternity, ICUs, operating rooms, endoscopy, oncology, cath labs, medical and surgical wards. And some of our last year's stats: we have emergency visits. We have 5,379 visits to the emergency room. We had 2,465 inpatients in the different wards. We had 170,279 outpatients at the doctor's office, and we had last year 1,660 surgeries. This is all in the from the private sector of the city. Some context, like talking more about what is happening in Honduras and the ASP. As I told you, there is no legislation or requirement from the country that regulates the prescription and use of antibiotics. At this moment, and for many years, a significant number of oral antibiotics can be obtained from small stores without medical prescriptions. It's like you can go to a small store near your house and you can buy any antibiotic you need. For example, amoxicillin is one of them that actually is like, this antibiotic does like nothing anymore as an antibiotic because of the resistance that this has created, because everybody with just a small cough, it's like, okay, take 2 or 3 amoxicillin twice a day or 3 times a day, and without a prescription, you can get it. At this moment, we have 2 hospitals under the jurisdiction of the Ministry of Health that they are working on pilot programs that are like the focus of the Ministry of Health, that they are trying to implement this program because they have seen that the antibiotic resistance every time more and more a problem. So they are trying to work on this. And one of the hospitals that it's working with the Ministry of Health, the program is led by an infectologist that is our reference infectologist also in Honduras Medical Center. and some focus themes about the hospital. We have as a hospital, we have tried to focus on patient quality and safety. Our hospital has consistently endeavored to implement action in this regard. We have been working with JCI standards, trying to obtain a JCI accreditation, and we have defined many of the structures of like the quality program, and we have a structure to like different committees that have like their focus areas, and we have two of them that works truly to the implementation of an optimal antibiotic use. We have the Infection Control Prevention Committee and we have the Pharmacotherapeutic Committee. These two committees have been working practically to implement the program. It is not really like so easy to do it, but we have been working on this so we can develop this program and have a better, a safer environment for the patients. Some of the functions that we have defined and some of the members of these two committees, for example, the Infection Control and Prevention Committee, we have that the members of this committee, we have the head of infection control, we have the infectious disease physicians or infectologists, we have epidemiologists and leaders of representatives from emergency services, intensive care units, operating room, endoscopy, cardiovascular center, clinical services, inpatient services, nursing, internal pharmacy, sterilization, biomeds, and environmental services. So this is like a very multidisciplinary committee that has the participation of all these areas, of all these people, so they can give their input in all the actions that this committee takes. So some of the primary functions that this committee has are the review and approval of annual program surveillance and prevention activities, the scrutinize epidemiological surveillance data and identify appropriate fields for intervention, ensure proper training of staff, inspection, control, and safety, examine or evaluate risk associated with the new technology and monitor its inspection risk before authorizing their use, review epidemic research and contribute to that activity. And of course, this committee has constant communication and collaboration with other hospital committees with a common interest, such as the pharmacy and therapeutic committees, antimicrobial use, biosecurity, health and safety committees. So these are like in general form, the functions and the members of the infection control committee. Then we have the pharmacotherapeutic committee. The members of this committee is composed of the chief of pharmacy, medical director, nursing management, infectious disease physicians, epidemiologists, medical representatives for surgery and pediatrics, head of infection control, and external pharmacy. So this is also a multidisciplinary committee, and we're trying to work hand in hand with the infection control committee. This committee actually tries or has to oversee the improvement and performance of the evaluation of quality in relation to the selection, the request, the transcription, dispensing, preparation, administration, and monitoring of medication throughout the organization. So they are responsible for all the scope of medication throughout the hospital. Also, they work closely with nursing management, medical direction, and infection control. So they implement different policies and oversight the medication management as a total. Also, the pharmacy is responsible for monitoring and tracking medication errors and adverse effects. And of course, one of their primary functions is to develop strategies for implementing and tracking an institutional ASP. Okay, so we are trying to work on this. As I told you, the country does not have a regulation, so it's like a little tough to control the doctors and all the practices of them. So we're trying to work and introduce this like new world of antibiotic control into the hospital. And we have some experience right now with some like activities we have done. Okay, just some reviews of the committee achievements. We have, as we had a problem before, the infection control committee and the pharmacotherapeutical committee before the doctors and the clinical staff, they didn't like take much importance. That they didn't have like the awareness or the importance of what was the actions or the functions that this company have. So now these two companies have gained importance within the medical community due to all the work that we have carried out and implemented measures. Now this company's structures serves as an advisor, as a point of recommendation, and establishes guidelines for infection control and medication management compliance. Okay, so this is one of, before we didn't, it's like the committee of infection control. Why do we have to pay attention to what they say, or that is not important? So now we have a committee and a head control infection department that actually is an advisor to almost all the medical community in the hospital. Also, previously, the infectious disease specialists or the infectologists did not actively engage with the hospital's patients because we have the like the head doctor that was managing the patient, but he wanted to control everything. So if the patient had an infection and if the patient had to use any like antibiotic that was out of his scope, he prescribed it and no one said anything. So now we have like changed that and tried to that every patient that has an antibiotic or an infection that has a multi-resistance condition, the infectious disease doctor or the infectologist goes and evaluates, and this this doctor is the one who takes the case of the management of the antibiotics in this patient. Also, we have nursing staff that has been guided and trained in the proper preparation and dilution of antibiotics, as well as its best practices. Before, we didn't have control the dilutions and preparation of antibiotics. We didn't have like any guideline that gave us like a parameter of how we do it. So we had like no control of this. So we before depended of the doctor about how we prepare or prescribe the antibiotics. And we have set up the initial steps for the implementation of the antibiotic prophylaxis guideline for surgery. This because we had before some issues with the prophylaxis that we were implementing, and that's what I'm going to talk to you about a little more. Okay, about the antibiotic prophylaxis, the hospital with the infection control committee and the pharmacotherapeutic committee, we developed a antibiotic prophylaxis guide for surgery. In some context of this, because as I told you before, due to the lack of regulation regarding the optimal use of antibiotics, the medical staff is not well informed on the subject, and there is limited awareness of its importance. As I told you, they don't like take this, or they didn't take this too seriously. In pursuit of a safe environment for patients, the hospital actually tried to determine through its committees that promoting an ASP is crucial. So we have seen how patients from different hospitals, from our hospitals, can get complications just because they have a bad management of their antibiotics and they got infections out of control when they're hospitalized. So this is one point that is critical, and that the direction, that administration of the hospital is focused on an implementation of an ASP. Okay, recognizing that this represents a significant change and challenge, the decision was made to commence with the control of prophylactic antibiotics administered before surgery. So we developed, as you can see, a policy throughout the hospital that was shared and socialized with all the staff that is part of this management of antibiotics, and where you can take like where you can inform, or you have a guideline about the selection of antibiotics, about the administration times, and about the prophylaxis duration too. So the doctors have now like a guideline so they can consult and review as a practice to administer a good or a decent prophylaxis as it is needed. The choice of choosing practically the prophylaxis before surgery was motivated by the analysis of what was occurring, okay? And this analysis revealed that we have non-compliance with the type, the timing, and the doses that scientific evidence has demonstrated to have a positive impact on patients. So, for example, we had a surgery where the surgeon or the anesthesiologist, who was the person who is the person who administered the prophylaxis before. So he was just like minutes before the surgery, before the decision, he was okay, let's give the patient the prophylaxis, but they didn't have like the infusion time. So they did it like with a push of the antibiotic through the vein. So it was like no reason at all that this was going to have an effect or a positive effect on the patient. Consequently, a decision was made to implement a guideline and policy to guide the medical staff in the use of prophylaxis. So we also have a guideline with the type of procedure, the specialty, and we have all the antibiotics, the recommended agent, and the alternative agents that we can use, their doses, their timing, and any consideration that it is important in this type of procedure. So this has been like like an intern document in the hospital that guides the doctors in this matter. We started this project about in July 2023. As you can see, although this prophylaxis project was implemented at this date, before July, we can observe that we have not achieved the desired compliance, where our goal was to achieve at least a 50% compliance rate for surgeries. So we have worked on this. We have identified corrective and improvement actions to enhance the compliance with this indicator, because it is pretty important for us to know what are we measuring, where are we at, so we can know where can we get better. We have identified, for example, the surgeries, the doctors that are not actually complying with the prophylaxis. So we have to make some interventions and we have to make socializations of the prophylaxis. And this is what are we working actually now. Okay. So some best practices while we were implementing, or while we're actually implementing all this guideline, all this project, our journey in this matter, we know that we do not have compliance at this point with what we were expecting to have, but we have received positive feedback from some physicians regarding the importance of the optimal use of antibiotics. At this point, some have started consulting the infection control committee or the head of the infection control committee, or the specialist of the infectious disease or the infectologist about specific cases when they have any doubt or uncertainties. So actually, the other we can say the best practice or support we have is from the hospital pharmacy, where we are implementing that the hospital pharmacy plays a crucial role in notifying the infection control committee about the dispensing of antibiotics to surgical patients. So in this case, we can control we have like a more specific controls of antibiotics even before they get out of the pharmacy. Also, we are aware that the knowledge of an ASP among many physicians is limited. So, and as a result, we have conducted and we will conduct several conferences and meetings to emphasize its importance. Some of the challenges we have will face with the optimal use of antibiotics. As you can see, we have many of them identified. Some of them are the lack of awareness, where the medical staff and the clinical staff is not actually, they have limited understanding or awareness in this matter. We have some resource constraints, insufficient resources. At this point, we don't have an electronic medical record. So everything we do it handwritten on physical record. So this creates like a barrier to have a more efficient control of the data and of the antibiotics that are dispensed from the pharmacy. Also, the resistance to change. We have situations in which the doctors are like, why are we gonna change if my prophylaxis, if I have done this like before for years this way and I haven't had any problem. So this resistance to change is evident and we have to work on that too. Time constraints, we have busy schedule from all people here, so everybody has multiple jobs and this limits sometimes their ability to actively engage in all the ASP activities. We have a problem in the country too with the availability of antibiotics. Sometimes we don't have original molecules from all of the antibiotics, and we don't have all the new antibiotics that are like coming out that have been demonstrated and that has like a major or like a wider treatment in infectious disease. So we have some limitants in this. Also, the data collection challenges, as I told you, because we don't have like electronic medical record, this makes a certain difficult to the collection data. We have limited training. We don't have like a full mounted program. So we are trying to work on that, where we can work with all the professionals involved in this, and we can promote the antimicrobial stewardship practices and principles. We have identified 2 communication barriers, and in this matter, sometimes the communication from pharmacy to doctors, infection control is limited, and this also can create barriers within the hospital. We also have, as a country and as a hospital that would measure this information, we have some high levels of resistance, antimicrobial resistance in the community. So we receive various patients that have this type of conditions in their as they are hospitalized. So this also creates a problem, because we don't have sometimes the molecules we need or the new antibiotics that can cover these types of infections. So yeah, for focusing all this that I have told you, what are our actions, or what is our action plans toward all this? Reading some article of the CDC, there are like crucial elements for the implementation and monitoring of antimicrobial stewardship program. Okay, in this regard, as a hospital, we are aware that the commitment from the leadership to fulfill this objective is fully necessary. So we need all the resources, we need all the tools, and these actually are provided to the responsible individuals. At this point, we're pushing the administration to acquire the new electronic medical records, so this can actually make our job easier too. So this is like the resources we're pushing this year to enhance this program. Also, to ensure results, a responsible party that includes the quality manager has been designated, and along with the support and management of the infection control team, the head of the infection control, and the pharmacy committee and the pharmacy leader, she is the expert in the optimal use of antibiotics, and she is the one that also can guide us better in this matter. Also, we are implementing different measures throughout the program, so we can actually evaluate and determine where are our weak points, so we can get better and implement actions in these points. Also, the communication and socialization of all the ASP, and also the antimicrobial resistance. All this data will be shared to the doctors, so they can know with the relations to the laboratory antibiograms and the antibiogram of the hospital, so they can know for sure which are the antibiotics that have more resistance normally in the patients that visit our hospital. And training and awareness campaigns will be conducted for all personnel involved. This is one of the most important, because we know that if we make the people, if we do or focus our actions to have everybody working toward this, it will be much easier and much had a better, much better outcome to the program and to the patients and to the hospital. So these are going to a conclusion, our action plans that we are taking and that we're working in this context.
Thank you so much, Jose Luis, for sharing this wonderful, interesting description of the journey that you had while trying to structure the antibiotic use. So let me remind once again for everyone that we are waiting for your questions and answers. Please, for your questions, please use the question and answer button, and we will address all the questions during the Q&A session that we have after all the speakers' presentations. So thanks a lot. In case something is not clear or you want to get an opinion of our experts, please type your questions. So thanks a lot, Jose Luis, for sharing the key elements of the stewardship program, antibiotic stewardship program, because I think for many hospitals that are just starting this journey, that's one of the key questions, really, especially in the circumstances like in your case, when there is no clear guidance present in the country. So the key elements, I agree with you 100%. So the committees is one of the key elements, is one of the foundations, as well as the clear framework. That's your policies and procedures that you develop on the antibiotic use, and of course training. So these are the key pillars. And actually, we already started to receive lots of questions about how to write a good policy on antibiotics, but I'm sure we will cover this during our discussion. And also, before we move to the next speaker, I wanted to remind everyone that we are issuing certificates for participation in these webinars, and that certificates you will receive by the end of January, because it takes some time to prepare them on your name. So now I'm happy to introduce our second speaker today. That's Julia Rodriguez from CEDIMAT. Those who already joined our webinars previously probably met Julia. So Julia, over to you.
Hi, Julia. Thank you very much for that presentation. Let me set up here my presentation. Give me a second. I think this should be working. Do you see the full screen, right? I guess so. Okay, so first of all, thank you, IFC, for the invitation. And there are two things that I would like to comment before I begin with mine. We cannot reinforce that phrase from Julia Kalimova that this is a journey, it's not a destination. The only thing that you have, it's a starting line, but it would not ever end. So maybe it sounds bad, but actually what it means is just that it's an active process. You will have all ups and downs, and you have to celebrate each achievement with the process of antimicrobial stewardship and infection prevention and control. And the second thing is that I am so happy to have heard the presentation from Jose Luis before and see how in Honduras you are working on this. And it's also very reassurance for us here at CEDIMAT, and for me especially, because I see that the process that they are going through, it's very much alike to what we are going through. And reading about it and seeing the recommendations and see someone that it's going through it, it's very reassuring. You know, you see yourself in a mirror, and we're all going through it. So hopefully during this presentation, you will understand a little bit more of what I'm talking about. I am Julia Rodriguez. I am a doctor and epidemiologist at CEDIMAT Medical Center in Santo Domingo, Dominican Republic. here we're going to talk a little bit about CEDIMAT. CEDIMAT is a tertiary level of care hospital in the Dominican Republic. We are a national reference hospital. It was founded by Dr. Juan Manuel Taveras Rodriguez, who's considered globally as the father of neuroradiology, given his work at Mass General. He left our country in a very difficult time and redid his medical studies in the US and had a vision of bringing all the knowledge and technology to the country, as well as providing training programs for doctors in the DR so we could have all of the technology that they had overseas here at home. CEDIMAT celebrates its 25th anniversary this year. We are growing from a diagnostics medical center to hospitalization and some services we only offer here, like cardiac surgery for children. It's the only hospital in the country that is taking care of congenital malformations. We offer almost every service, medical service that we can have, from cath lab, general surgery, orthopedics. We have it all except for maternity here in CEDIMAT. We are oh wait, I'm trying to change here. We are a 200 bed hospital. This is our second building. It's a cardiovascular center, and this is how it looks. This is our inside. This is the modern, brand new 5-year-old building in our hospital. And this is the old one. You can see it's just one first floor. It was only diagnostics, and then they built a hospitalization building, and we grew to the cardiovascular center as well. I put this picture here because we are not only our beds and walls, we are the people and the doctors and the team that provide care. It's the most important thing. The hands and the brains are working here. And none of the things that we do here could happen without the people. So we do have great technology, but neuroimaging, research, teaching, publication, and all the research that we do, it's been over 600 projects that we have been involved locally and internationally. We have gotten some grants for that type of work. Our publications and our doctors have been recognized by the American College of Cardiology, the American College of Physicians. They are fellows over there. Some of them are board certified. And if you want to know more about us and about our services, that's our website, cedimat.org. You can find a lot more about us. So, before we talk about Antimicrobial Stewardship Program, we need to talk a little bit more about the Infection Prevention and Control Committee and how it works, so you can get a little bit of context of what this this journey it's all about. We, just like Jose Luis in Honduras, we have the chief nurse officer involved in the committee. We have infection prevention nurse. We have an infectious disease doctor in our committee. The laboratory director is involved, and as well as the microbiology lab coordinator, the medical director, representation, operations director, pharmacy, clinical hospitality, and concierge, and myself in epidemiology. We also do same type of work. We meet every month so we can review cases that we've had and what are the trends on the 4 most important infections that we follow up, UTIs, bloodstream infections, surgical site infections, and respiratory infections related to the ventilator. Then we do, obviously all of this is done with the help with the infection prevention nurse who's in charge of the surveillance and to bring us the red flags if anything is happening between meetings. We do trimestral presentations of all of this discussions that we have every month so that everybody knows where we're going, and to have like a moment where you can get up to date on the trainings that we've been doing, and just like a small reminder that we need to have infection prevention and control always in mind. There are training sessions for hand washing and other measures that need to be done. There's induction for new personnel that was implemented 2 years ago. We already did induction. However, we didn't put a lot of information on infection control to everybody. We saved that only for clinical personnel, but now we have a specific point in the induction for everybody to be involved and to work together for patient safety. Also, there are extraordinary meetings for outbreak control. There has been a couple. It's not a perfect program. You will always have that in infection control. You need to identify what's going on and try to work through it the best way. The best way is with your team. So I don't have great pictures of our committee, but here, although they look all distracted, we are doing a simulation of what needs to be done in case we have a national outbreak or an epidemic or another pandemic. So here we have involved in the back, it's our infection prevention nurse, there's the pharmacies, there's the operations directors, there's the head of the emergency department, there's also our CNO and our new head of quality. Just now, within the past 2 years that we've been working harder on the JCI accreditation journey, we've now organized better the committee because we developed the infection prevention and control committee about 10 years ago, but it would work a little bit independently. Now we have a different structure where we report to the quality office and the quality office to the quality committee and the committee to our governance body. So there's more information at all levels and more involvement within the program. Stewardship programs in general are an effort to measure and improve how antibiotics are prescribed by clinicians and used by patients. The idea is to improve and to make effective management of infections and to protect patients from the harms that can be caused by unnecessary antibiotic use, like antibiotic resistance. So this is a very difficult idea to get in the mind, especially of patients. And in our country, there's the usage of antibiotics outside of the hospital, it's very high. So we do have a lot of resistance, and it's difficult to change the mindset, just like in Honduras. existing guidelines include the Infectious Disease Society of America. They have guidelines, the SHEA, which is the Society for Healthcare Epidemiology of America, the American Society of Health System Pharmacies, and Joint Commission. They all have guidelines and recommendations where you can check and see the best one that suits for you. Something that we've learned through this journey is that not only we are going to be changing in time, but that we need to adjust whatever there's published out there, because it doesn't necessarily works for us. Okay, so what the stewardship program should impact is to have the right dose at the right time, and the right drug through the right duration. And this should help you with infection control. This is not something that we are just talking about. It has been studied. CDC has this publication. It's available to you. It shows the core elements of hospital antibiotic stewardship programs. We're going to talk about it. We didn't do exactly this, and we'll explain why in a little bit. But these are very important points that definitely with time, we've seen that it is important and that maybe we should have done it just like this. So there should be hospital leadership commitment. So we need necessary human and financial and information technology resources. It sounds simple to just figure out your local epidemiology, do a guideline, and tell everybody to just follow that. Or at least it sounded simple to me when we first started the program, but it's not. And you need a whole logistics behind it, from the buying the medications, having them available, the commitment to have personnel that will control the medications for the monitoring of the consumption of the medications, and that it's like we were showing before, right drug, right time, right dose. It's not easy to monitor all of that. So you need commitment at all levels, especially at the high one. The team needs to be accountable. You need a leader and you need co-leaders. You need a team, but you need people, a team that everybody can trust, that they don't think that you are working because there's a conflict of interest, that you will have a pharmaceutical company paying because you are prescribing their medication, or that the infectious disease doctor only wants to do this because they want to get more consults during the hospitalization process. So you need to make sure that whoever is the face of this is accountable for their work, that people trust their knowledge, and that they see and understand that there's no conflict of interest. Pharmaceutical expertise is also necessary. There has to be a pharmacist that can co-lead the stewardship program, so it can be implemented effectively, and it can monitor and control the dispense of antibiotics. Action. So there needs to be a plan. You need to plan and implement interventions, not only say that you're going to do things, but actually do it, because then you might lose perspective, you might lose commitment, and you need to do the work, but also to provide feedback, because if not, it's going to look like you're just talking about it and not doing anything. But when you monitor and you give feedback regarding to what has been happening after you designed all of this plan, people will be reassured and will say, this is good, this is bad, and they understand that the program is alive, that it's not something just in paper in the wall. So there comes tracking, reporting, and Education, this is those are the most challenging, the tracking, the monitoring. Jose Luis was talking about not having an electronic medical record. It's not always the best. We could say we have it. We implemented it on 2015, and not necessarily it will solve all your problems. So we were monitoring perfectly that the consumption of the antibiotics, but it was very difficult with the electronic medical record to identify if it was the right medication for the right infection, because not necessarily when you have a patient that is hospitalized for a surgery, you don't have anything electronically that will automatically, I don't know, put together that is this antibiotic for this infection. So you still have to do a lot of work that it's manually. It does help. we do have good numbers for consumption and that type of follow-up, who indicated what and when, but we still need to do rounds so we can monitor that, and we are just improving that at the time. So reporting and education, also very important, what I think we already talked about. So an overview of our antimicrobial stewardship program. So as I was saying before, we started working things a little bit independently. So the Infection Prevention and Control Committee was not, it was a little independent. It didn't had someone actually looking after the work that we were doing. We were just working on patient safety, but independently. Now that we have more commitment of our leadership, from the administrative to the medical, it's working a little bit different. And doctors were not as involved at the Infection Prevention and Control Committee when we started with the stewardship program as they are today. So infectious disease doctor and myself, we started working this. We thought it would be easier. It was just, okay, let's look at our local epidemiology. What's the resistance profile that we have? And let's do a guideline and let's just tell everybody how they need to do this. We didn't see that there was actually a relationship with that work and the Infection Prevention and Control Committee. But to be able to monitor all of that, we needed the help of the surveillance team. And that's what the Infection Prevention and Control Committee is. That Infection Prevention and Control nurse is the one that helps us with that. And there's where we have communication with the microbiologist, because we learned that some doctors were not using the antibiogram correctly, or that they didn't know what it was. They were asking for the resistant profile of a drug that didn't actually apply for that. So bringing the stewardship to the committee is what helped us with the communication and to identify that everybody had different struggles with the same optimal use of antibiotics. So hopefully that works for you, and the program needs to depend on the committee because of all the communication difficulties and challenges will be tackled right there. We started it following the guidelines from WHO and CDC, using HUNET and a consultant that came with us to show us how we should do the local epidemiology and what we needed to take into account. He trained our doctors, and then we trained the rest of them. There was, just like in Honduras, we had a lot of resistance of doctors changing their prescription. And then when we got them to change, it was difficult for them to stop, and we'll see that in a bit. This was our local gram-negative resistance profile. We're not going to stop a lot there, but this is what we did, and we included this at the first page of our policy of and guidelines for the usage of antibiotics. We train people on what was the stewardship, why do we need to do it based on what we saw here. So making awareness that we had 85% of resistance or 66, or that we were actually in trouble with our antibiotics. And we had to do like 12 different training sessions because everybody has a different time set and responsibility. So it was very difficult. And doing lots of them is what helped, and inviting them and how can you get involved. What we included in our guidelines were just like Jose Luis, surgical prophylaxis, abdominal infections, UTI, treatment for neutropenia, septic shock, community-acquired respiratory infections, and all of that. So we looked at our resistance profile. We went to every clinical guideline for every different clinical condition. And then based on that, our infectious disease service got involved and created the guideline. So best result was when we started seeing a 20% decrease of resistance on our E. coli for ciprofloxacin. Unfortunately, after that came the pandemic, and we couldn't actually follow up and see what else we had, and also people didn't pay a lot of attention to that. So with that also came bad results, which was the appearance of resistance to prophylactic antibiotics, because we got doctors to change from their prescriptions before to one based on a local epidemiology, but then we were not monitoring that they would stop it at the right time. So we had same antibiotic for days, like they started before the surgery, but indication is to stop right there after the surgery, and they didn't feel comfortable with it, and they continued to prescribe it for several days, and now we had to change our antibiotics because that gave us some higher resistance profile, especially for ampicillin, which was one of the antibiotics that we were using. So challenges. One more minute for me. Community use of non-prescribed antibiotics gives us a profile of resistance that is very difficult to manage. Changing the prescription behavior in hospital and outpatient based on local epidemiology was difficult, and when we got to the difference, to the change, then they still don't trust it enough to just stop using it. Doctors think that antibiotics are going to prevent their patients from getting infected, and they're just creating a more difficult environment for us. Communications between doctors, laboratory and infectious disease service, having timely de-escalation, and the resources for the surveillance and monitoring. We have 200 beds, and we only have 2 nurses for infection prevention and control, which seems to be enough, but they also have other responsibilities. As myself, also as an epidemiologist, I also have other responsibilities. So we don't have, everybody here is like that. So the stewardship, it's like the extra that everybody keeps moving because we are committed to it, but we need leadership to help us with more resources. These are the lessons that we learned. Antibiotic selection for prophylaxis should be always based on the risk according to procedure. However, every patient can be an exception. You have a guideline, but you need to have different options of antibiotics because maybe the antibiotic's not going to be available, or maybe the patient had it a couple of months before. So you need to give at least 3 options within your guidelines. Prolonged prophylaxis can definitely increase resistant traits. Continuous surveillance is fundamental to elaborate appropriate recommendations and maintenance of the program. You need to know your local bugs and you need to keep it up to date because they change. We were going to change every year, but we have now decided to do it every 6 months because of that. Communication between doctors, microlab is crucial. All stakeholders should be aware of any changes and everybody should be involved. This is what we're planning to do now. Now that we are working together with the Infection Prevention and Control Committee, we are updating the guidelines and see what everybody can offer in the process. We need to retrain all the personnel. We need to focus surveillance on the ICU and on the prophylaxis. We try to do the entire hospital. And with the lack of resources, we were just doing everything and we were not being enough. So we decided to focus on the higher risk areas, which is only the ICU. And it's easier for everybody to do the rounds and to do the monitoring and all that. And once we have that ready, then we're gonna go and change again to the entire hospital. Monitoring commitments so that we can give the feedback. That's our plan now, to be able to feedback everybody on the changes on the profile, the resistance profile change, so that they can see that the program is alive and that prescribing carefully can actually make changes. And hope this was not too long. Thank you very much. This is my contact information, and hopefully we can have you here for anything. And I don't know, I live where you vacation, guys. This is Dominican Republic. Thank you so much.
Thank you so much, Julia. This looks marvelous. So thanks a lot for sharing, again, the details of your journey, just exactly as Jose Luis. This is, I think, is super useful for our audience. And thanks a lot for also sharing the lessons learned and things which should not probably done the way you were doing it initially. I think this is also, yes, we share all the presentations. I'm answering the questions that we receive in the chat and in the Q&A button. So we definitely share the presentations. Don't worry about that. You will receive all the slides and you will receive all the bullet points that Jose Luis and Julia developed for you. So you will have it at hand as guidance when you decide to develop and implement your stewardship antibiotic program. And also we receive a lot of questions in Q&A button, and our speakers, our panelists are already answering these questions. So don't wait. If you have any concerns or anything is not clear to you, you can use the chance now. We'll definitely have our Q&A session and we'll still discuss many of the aspects and many of the dubious moments. So one more organizational issue. In order for you to get a certificate with your name, you will need to fill in the survey on exit. It's very easy. Once you leave this event, you will receive you will be automatically reverted to the survey on exit. And there you need to type the details that you want to have on the certificate. Make sure that you don't skip this step. In this case, it will be very easy for us to provide you with the certificate. This is a very important technical detail. And let me remind you once again, you will receive the certificates by the end of January. So if you don't receive it tomorrow or the day after tomorrow, don't worry. They are still in the process of preparation. Everything is all right. Also, I wanted to tell you that apart from quality, our healthcare advisory team in IFC is also having such initiative as ethical principles in healthcare. Probably you already heard about it. So you can also subscribe to ethical principles. It's absolutely free of charge. And my colleague Maria will now share the link. So for all the hospitals that subscribe to ethical principles, there are closed events. So it's like kind of club. And the events that are in the process of planning, they will be about safeguarding information and responsible use of data. So we believe you might find it useful. So use the link to subscribe to EPIC. Also, we received multiple questions today on the role of the lab in antibiotic stewardship program and specific how-tos. We actually foreseen that. And that's why we invited a member of our team, whom you might already know, Manuel Giraldo, and he will tell specifically about the role of the lab and also share tips and tricks in the antibiotic stewardship program. So Manuel, over to you.
Yes. Okay, cool. I think everybody can see my slides. Well, thank you, Julia. And I want to thank Jose Luis from Honduras Medical Center. I want to thank Julia from CEMAT. Both great presentations. It was great to see you as well. And hearing from you the challenges that you're going through in your countries and in your organizations was amazing, but also hearing the amazing things that you're doing and moving forward your teams as far as helping the physicians to understand the proper use and to teach and to educate the staff and to implement best practices for the optimal use of antibiotics is amazing. So yes, Julia, the role of microbiology, and I saw so many comments and questions from the team, from the audience about the role of the microbiology lab. So we'll talk about that in a minute. Let me introduce myself and a little bit of who I am and where I work with. So my name is Manuel Giraldo. I work in lab medicine for the last 35 years, working in different capacity. Back in my early days, I work in microbiology. I'm a bacteriologist from profession, and I have a few specializations in quality and critical issues in terms of healthcare administration. So I work in Toronto. For the last 25 years, I've been working in different teaching hospitals. The last one I was North York Hospital, where I work in different capacities as a director of a lab with 150 staff in lab medicine and genetics as well. So here is the micro lab. Here is what the micro labs gets involved in. And normally we said that the lab medicine department, the lab contributes to at least 70% of the medical decisions are coming from lab medicine. Yes, and this is more true. It's very true with microbiology, where you can basically, physicians cannot really diagnose or cannot prescribe antibiotics without the results from the lab. They want to know what bacteria, what microorganism is the cause of that infection. And obviously, we like to know what's the best antibiotic to treat that infection. So here, there are different ways of microbiology. Still, a lot of people use manual testing. Plates, bacteria are cultivated in agar, and there are all automated solutions today, fully automated solutions for microbiology, where you can see rapid testing not only with instruments like the ones that you see in the screen, the Bitech, but also you see a lot of involvement of molecular testing today for diagnostics of microorganisms and also for resistant patterns. So I'm going to take you through that quickly. It's only 5-10 minutes presentation. This is not going to be a lengthy presentation, but I'm just going to quickly give you some key points, key messages for this topic. So again, like I said, you have your antibiotic. You can do the place on agar. Remember the old days where you use the Mueller-Hinton agar. You have your zones or inhibition, where you measure that halo and you can calculate the amount of sensitivity or resistance or susceptibility for any antibiotic, specific antibiotic, and you use that for gram-positive, for gram-negative bacteria, depending on what the source. If it's urine, if it's wounds, you will put different antibiotics, disc. And then you have your machines who will give you by dilutions, like the one on the right on the top. You can do the antibiotic testing as well, the susceptibility testing with these instruments. By dilutions will tell you which bacteria are resistant or sensible to X antibiotic. And then this is something that Julia mentioned on her presentation at CEMAT. They do the annual antibiogram or antibiotic susceptibility cumulative antibiogram, where you can actually see the amount of resistance for different antibiotics. You can divide it up by gram-negative, gram-positive. There are different ways to do this by the antibiograms. annual antibiotics. And one of the things that we want to stress is that these antibiotics shall be hospital specific. So we cannot copy Selimat antibiogram and put that antibiogram to hospital, Honduras Medical Center, vice versa, or nowhere worldwide. You have to develop your own susceptibility patterns for your organization, because they all depend of the population that you actually serve. So in Toronto, for instance, if you go to any hospital, you'll see their own antibiogram. And if you even try to compare those, sometimes they are so different, because you have a large population of immigrants in some of the cities in Toronto, where they don't have the same patterns of resistance as the other ones. So it's very specific. And again, this is something that the microbiology team will do on an ongoing basis. We'll collect that data. You can do this manually, or you can use this machine that I'm showing you on the top, where you can pull data and you can say, okay, show me the resistance for ceftriaxone, for penicillin, for gentamicin, and the computer will give you automatically those patterns. Or you can pull data. If you don't have those instruments, you can pull data. Or the folks that don't have those access to that data, you can use it from your system LIS, or you can use it, you can pull records and you can see resistance and build that antibiogram, which is very helpful, especially when you have infections that you don't have immediately access to the results. You can see the patterns and you can start treating your patients. Of course, you want to take the samples before you treat the patients, but sometimes you have to start intervening those cases right away with some of those historical patterns until you get the final result. So here are a few examples of how the microbiology contributes to the whole overall antimicrobial stewardship program. So number one, it's just a quick definition. We have already spoken about this, is to ensure the optimal use of antibiotic treatment, and that results in the best clinical outcome for the treatment or prevention of infection, with minimal toxicity of the patient and minimal impact on resistance, right? And here are a few examples of how do we do that? How does the microbiology team, and I know that I'm talking to many of the lab technologists, bacteriologists, microbiologists, people who are working day to day to provide those best results. So we or people will do this by providing, revising, and publicizing annual cumulative susceptibility reports to clinicians. And those are the charts that I just showed you in the previous slide, where they will give you patterns that work for ID physicians, to identify physicians, infection control physicians, infectious disease physicians, to interpret this data, to update recommended empirical regimens. Another way that we promote, microbiology promotes, is that they use a cascade reporting. In some cases, we want to say, okay, you know what? Do not report carbapenem susceptibility when you have a pathogen that is susceptible to a narrower spectrum drugs. So that's another example of how the microbiology can provide meaningful data to physicians. Repeat testing and promptly send to reference lab unusual susceptibility profiles. For example, Staphylococcus aureus resistant to vancomycin. And also another way that you can collaborate in this effort with pharmacists and infection control physicians is to improve reporting of minimum inhibitory resistance for doses based on pharmacogenetic targets. So I gave you the source for this. You can find more information on that if you're interested. But these are just a few examples of how microbiology can contribute to the whole stewardship program. Last, a couple of more slides, just to keep us in mind that there are a few bacteria that are resistant to different drugs. And if you remember all days, we all talk about MRSA, methicillin resistant. Then we discussed later that there were some VREs, vancomycin resistant to Enterococcus species. Then later we start discovering that there are more resistant patterns, and then you have extended spectrum beta-lactamase bacteria such as E. coli and Klebsiella, And later on, you have more bacteria that have developed more resistant to other antibiotics, such as the CRE, the carbamazepine resistant. And then now we talk about multi-bugs, multi-resistance bacteria that are resistant to multiple antibiotics in different classes. And there are countries that are well known for this. Unfortunately, these bacteria. In Asia, you see multi-resistant bacteria. Some of these countries are using multiple antibiotics. And one of the issues that's happening is because sometimes they don't have a strong program for the proper use of antibiotics. And obviously, if you don't use your antibiotic properly, you're going to create resistance. If patients don't take antibiotic properly, they're going to create resistance. If they just take halfway, they don't kill the bacteria. If we start using empirical combinations, obviously the bacteria are going to develop those resistant to those antibiotics. And you can see some facts. 2.8 million infections occur in the United States each year due to antibiotic resistance, and more than 35,000 people die as a result. In addition, nearly 200,000 people in the United States require hospital care for C. difficile, Clostridium difficile, and at least 13,000 people die in 2017. So let's keep in mind that C. difficile is one of the bacteria that will be also responsible of the deaths, and that happens when you use antibiotics for a long period of time. They develop this C. difficile, and there are treatments today for C. difficile as well. Anyway, a few key messages for the technologists who work, microbiology team who work in the lab. Just remember that you want to have strong policies and procedures available for the staff, how to perform susceptibility testing, how to do the planting, the cultivation, to ensure that you have proper techniques to avoid cross-contamination, that you're also protecting your staff, how to collect the specimens before antibiotic treatments. So ideally, the way that you want to stress that with your physicians, you want to collect the urine before you start doing antibiotics, you want to collect swabs, you want to collect the full specimen, obviously as the ideal. And for those that are planting specimens, to try to use selected media that is going to help you to isolate and recover pathogens. And then we want to have, for the docs that are sending the specimen, for the nurses that are collecting the samples, we would like to have, preferably, we would like to have tissue aspirates and not only just the swabs. Swabs are good for nasopharyngeals and for viral respiratory infections. And specimens of poor quality must be rejected. Everything that grows is not always relevant. This is key. If you have a urine with multiple microorganisms, it doesn't mean they're all pathogens. It could be a contaminated urine, the same with wounds. So susceptibility testing should be performed on clinical isolates, and not all microorganisms recovered in a culture are key or significant for reporting. So lastly, my last slide talks about choosing wisely. It's an international campaign that has been spread to about 30 countries worldwide, where they have developed over 1,000 recommendations. We're doing a lot of work in mainly in Europe, in United States, in Canada, but now we're expanding these recommendations to developing countries, to emerging economies, and in Latin America, we're doing a tremendous job with implementing this campaign in many countries in right now. So I'd like to mention that if you Google, and I'm giving you 2 resources at the bottom, you can click on those resources, those links, and it will take you to websites where you'll find 1,000+ recommendations for all specialties. I brought to this presentation today a few recommendations that are based on evidence, on medicine, on literature, with from different providers, from specialties. And here are top recommendations for international societies in lab medicine. Do not routinely prescribe antibiotic for acute mild sinusitis unless symptoms are seen for at least 7 days or worsen for initial clinical improvement. Another recommendation from clinicians is do not prescribe antimicrobials to use bacteriuria in older adults unless they have specific urinary tract symptoms. And then for country specific, like I said, this has been implemented in over 30 countries. You can Google it, like I said, you can find recommendations for emergency care, for pathology, for transfusion medicine, for nursing, for gynecology, for many practices. You can find those all recommendations are available to you, but I just pull a few for today. Here are a few two country-specific recommendations that you might adopt, discuss with your physicians in your facilities, is from the Microbiology Society in Canada. Do not prescribe aminoglycosides such as gentamicin, tobramycin for synergy to patients with bacteremia or native with valve infecting endocarditis caused by Staphylococcus aureus, or do not prescribe antibiotics routinely in adults and children with uncomplicated sore throats. Okay, and that comes from the emergency physicians as well. So this is all for now. I want to thank you again, and I'm happy to answer some questions in the next chat. Thank you very much.
Thanks a lot, Manuel. Very useful information. And let me remind you once again that we will share the slides, so you will get all these tips, tricks, advice, and references from our speakers. Don't worry about that. And also, I wanted to conclude that actually we are now moving to our question and answer session. So because it's 10 minutes to the scheduled time, almost 10 minutes, we will stay a little bit longer. Hope you don't mind and hope you will enjoy it and find it useful. So we will have another like 10 to 15 extra minutes, most likely, because we have so many questions. So our speakers today already answered many of your questions in question and answer section, and also shared lots of good references for CDC guidelines and lots of other things, both in the chat, in the question and answer section, and in their presentations. However, we still receive a lot of specific how-tos about how to set up the stewardship program. So I thought, let's revisit this question once again, and let's give clear guidance where this information can be found, especially for those countries that do not yet have it at the national level, the guidelines or the legislation regarding the prescription of antibiotics. This will be very useful because questions are very specific, like who can be the chairman of the committee or who is recommended to be the chairman of the committee? Are there TORs for the committees and where to find them? Where to find guidelines and what time antibiotics prophylaxis should be given, what time in advance to the surgery, etc., etc. So I'm sure we cannot cover all these questions in detail, but at least we can refer to specific sources and which is the best way to find these sources. Who would like to be the first to answer this question? Jose Luis, Julia, Manuel?
Hi. I was trying to type an answer to that question, and it took me so long. But yes,
Great.
there are TORs for every committee in our hospital, so we can have everybody know what their role and responsibility with the committee is, because at the beginning everybody's involved and committed and excited, but it's a journey and it takes time, and then people leave the hospital and other people come in, and you need to have everything set up and ready so that you can continue the role, right? And to have it in our hospital. The head of the infection prevention and control committee is the CNO, is our chief nurse officer. She's the one that almost 11 years ago did the first course about it, and when we started thinking about JCI but didn't actually know a lot about it, funded the committee and trained her nurses and gathered the laboratory and the doctors to actually have this. since nurses have their safety goals very fresh, and one of them is infection prevention, and they are the ones very close to the patients with it. They really have a lot of information and a lot of responsibility in the role. That could be something good and bad. It's not necessarily the best practice, because since they do a lot of the work, they're also measuring themselves. So they are being both parts. But what we've done is make the committee bigger and write the TORs so everybody know their role, and we try to be the most transparent possible. I don't know if that answers the questions, or I think.
Thanks so much. So Jose Luis, and what about you? Especially that you said in your country there is no legislation yet, or there was no legislation. So what sources were you using and found useful?
Well, we actually use as we are going to, like, working with JCI, we try to find like JCI reference in this matter. And not always these guidelines or this information is totally like useful to our country. So we also use like guidelines from other countries. We have like very good guidelines from Mexico, from Colombia in the use of this. So we try like to make something like a hybrid so we can implement it here in our country. Because we don't have the same antibiotics disposition, availability in our country, so we have to like get a something that adjusts to our situation. So that's what we're working on, and we have like different guidelines. Yeah.
Thanks so much, Jose Luis, because actually I agree, and Julia mentioned that as well. There are always local specifics, and as Manuel shared with you some Canadian guidelines, this should be always adapted to the local peculiarities, and it cannot unfortunately be borrowed 100%, just taken and inputted into somewhere, because there are specifics. It has to be it has to be adapted, so use it more for inspiration and also to get clarity and learn from other countries' experience. And also, the other question is actually about specific treatment protocols and use of antibiotics for specific conditions. That's another very common question, and where to look for that. Because building a structure is one thing, how to develop policies, TORs, etc., and then specific protocols, which would be the best source. This is number one. And number two, which you would recommend to do it department by department or condition by condition, like for instance, Jose Luis started with surgery, or to have it along all the hospitals so that all the staff are involved simultaneously. Which do you believe would be the best way, or maybe based on your experience, the way it's done in your hospitals?
Well, in our hospital here in Sedimat, we okay. First, we try to go through the most common infectious diseases that we had. So, community pneumonia, community-acquired pneumonia, or hospital-acquired pneumonia, or bloodstream infections. We started with now that I think about it, we started with the 4 infections that we are in the surveillance program for the infection prevention and control. So bloodstream, UTI, pneumonia, and surgical site infections. There is where it's very important to have that communication with the lab, because they can tell you for those what were the results of the cultures and what's the resistance profile. And then you can go to the international guidelines for pneumonia and look at your profile and look at the options of antibiotics and then decide on it. I'm not the expert on that matter, because that's the ID doctor, the infectious disease doctor, the infectologist that actually decides on that part. But this is how we did it. We started with those 4, and also with the ones that are the most common infections in our hospitals. So febrile neutropenia, patients that came for cardiac surgery and then got infected, or so we went from prophylaxis to bloodstream infection. That's how we did it. So which ones are we surveilling? What surgeries do we have? We try to look for a guideline for all of the surgical procedures that we had, especially obviously the elective ones, and then we try to monitor. We are monitoring the antibiotic consumption there and the
Thanks.
changes on the resistance profile.
Yeah, very
Manually.
useful, Julia. Thanks a lot for sharing your experience in this area. And Manuel, you have a hand.
I do, and I want to complement. I want to add to just what Julia just mentioned. It. I think it's key also, Julia. I'm pretty sure you have this because I seen it. There is something about formulary. So a formulary for the use of antibiotics, proper antibiotics. So these are formularies that every organization tried to come up and develop based on patterns of resistance. And these are formularies that will dictate, is done by pharmacy, but they will dictate and will tell the physicians, okay, here, for if you have otitis, this is what we want you to treat these patients in our organization. If you have urine infection, this is what the antibiotics that we would like you to use for urine infection. You have endocarditis, these are the antibiotics. So that's helpful because with the physician, if you have multiple physicians coming to your organizations as a consultants, and they're used to prescribe antibiotics one way or the other way, no, now when you come to my organization, this is what we use at SEDIMAT or Honduras Medical Center, and these are the antibiotics that based on our population, we want you to use to avoid multi-resistance and to treat properly our patients. So this is a good thing that actually they use for different conditions. I believe that Julia has that at SEDIMAT as well, Jose, right?
Yeah, thanks a lot, Manuel. So unless Jose Luis wants to comment on this question, we can move to the next one, and it's gonna be a tricky one. So would you recommend to use or prescribe antibiotics by telehealth? So remotely, without, seeing the patient, taking the samples. It's actually a question which came several times. So it's really important issue and really a tricky one. So if the patient, you cannot examine him and take the sample, but at the same time, it seems like this is like otitis or something else. So he probably needs antibiotics. So what you think would be safe next steps in such a case? I knew it's going to be tricky. Manuel, do you want to start? Because we discussed this case with you while preparing. Let's describe maybe the ideal approach.
I think it's better if you ask that question to Julia. She's a physician, so she might be able to answer that question more than Jose Luis.
Okay. Julia, do you want to address
Well, I'm the physician that doesn't work in the clinical area, but well, in our experience with telehealth, what I've seen that other doctors that actually do it have said is regardless of, that they will always prefer to be able to examine the patient, but sometimes with telehealth, the patient didn't come and you didn't examine it, but you have an X-ray available for respiratory tract infections, for example, or you have a bloodstream, or you have a complete CBC that you know that there's an infection. So they have done it. They don't prefer it, but they have done it. Especially for respiratory ones that you don't actually culture it anyways at the hospital. But here we do telehealth more as a follow-up than as a first-time visit. So I wouldn't say that we actually practice like that, but I think, yes, you can. The most important thing here is educating the patient. Someone was asking about it. when you discharge your patient with antibiotics to go home, you need to emphasize the importance of taking it at the right time for the amount of days, to complete it. And sometimes we scare the patients, like, if you don't do it, you're gonna feel better, but you need to continue it, because if not, it's not gonna work again. Be very emphatic at discharge. And also, we do have, for the safety of the patients, you do have a short-term follow-up visit, a consult. You have it for after surgery, and you also have it for a patient that has been hospitalized. You will see them probably in the next 10 to 15 days. So ask about it. And how did you take it? When did you take it? Was it available? So do you know how the patient did, and maybe get some information that might help you with other patients, like it was not available at the pharmacy, it was very expensive, um, and stuff like that. Educating the patient and asking about it.
Can I just add to that, Julia, that yes, in Canada and United States, there are board certified physicians. They can actually prescribe antibiotics online in telehealth. And mainly they do, like Julia mentioned, in respiratory infections such as sinusitis, pharyngitis, acute bronchitis, or acute otitis media, right? This is the usually common conditions that they do. But like Julia mentioned, they had to be prescribed with very careful consideration, and they had to make sure that the patient understand. They usually happen also after the first visit. So they kind of refill their formula if necessary, kind of consider and talk to the patients. But the preferred way is to do it in person as well, just because you want to check and assess the patient properly.
Thanks a lot, Manuel. Thanks a lot, Julia. I think this is very important point. Very much appreciated for your answer it in detail, this question. So another question actually refers, again, it's a very common one. Even we heard it a lot before the webinar. We hear it from multiple medical facilities, how to bring staff on board. Any tips and tricks? So, okay, the medical facility developed TORs, created committees, created chosen guidelines and protocols, and then doctors do not follow it. And they are experienced, they have their own opinion about it. And is there any instrument to make this whole system work properly?
Well, for us, I was trying to explain, but I felt like I was running out of time. But what we do is, at first we could see that doctors were saying, I've been prescribing this antibiotic for 20 years according to this international guidelines. And they felt like our local guideline was not up the level of his international one. So we showed the local resistant profile, and we showed international guidelines according to that. So if you have this guideline, but this is what we have here. So what you are giving is not attacking the problem. So look at these guidelines that say that when you have this, that is actually what we do have here, will work. And that's how we first got them involved on it. And we even had doctors that would not prescribe the medication here. They would do it outpatient and have the family bring the medication on their purse. Like, it was very, very, very difficult. So what we did afterwards is, or what worked last year, and we saw a little change, and that's why we are focusing this year so much in monitoring and feedback. It's that when you show them, this is what we had on 2018 when we started it. None of you follow this, or you follow this, and this is where we are today. And now they're like opening their eyes and seeing, well, what we do or what we don't do is actually affecting the local resistance profile. So maybe to be aware that change is not going to be morning to tonight. It takes time. So make sure you you have a good communication strategy, and then you monitor and you give feedback. Feedback is very important in having them changing their actions, the prescription
Thanks.
costumes.
Thanks a lot, Julia. Manuel, you wanted to say something?
Well, kind of. I mean, you want to show it's something about quick wins. So anything that you achieve after implementing your best practice for optimal use of antibiotics, show the results and share that information to the physicians. They can see the benefits. Why are we doing this, right? So if people see it, what are the benefits of using these antibiotics and how this is impacting my population, reducing the number of resistant, treating properly conditions, then I think that's another way to engage in an ongoing basis our physicians as well.
Thanks a lot, Manuel. And unfortunately, we are running out of time. So thanks a lot. So we will take one more question. Thanks a lot to all our speakers who answered in the Q&A section almost 30 questions. So if you're interested, you can visit and read. And we will try to address those questions which remain. Unfortunately, physically, we cannot address all of them at a time. However, one more last question. I think it's Manuel, it's the question that we discussed during the preparation of this webinar. If the patient arrives and it's obvious, the patient is admitted to the hospital, it's obvious he needs some antibiotic, and then probably he might need to change it. So the sensitivity test, when it's the right time to take it, and how to organize this process smoothly. Do the antibiotic before the test, do it after the test, etc., etc. So all these complicated situations when you need to act very quickly, but at the same time choose the right medication.
Yeah, and I'm happy to answer that, but I know that Jose Luis was going to add something to a previous question. I don't know if he wants to do that.
Oh, sorry, Jose Luis, you're welcome.
Okay, no problem. No, I think that the last question was well, the thing is that the important is the totalization of the what are you doing, the measurements that you are, what are the outcomes that you are getting from the implementation, and if you socialize and compare that, as Julia said, before and after, how are we doing, and what is the results of this, and that's like a way to convince doctors, because sometimes they think that they know all and that they have the reason of all, but when we have an equipment that is like a team that is trying to convince the doctors, like trying to focus them on what they have to do. So I think that it may be a good experience, as we had with other implemented actions in the hospital, not because we're starting with this ASP at the hospital.
Thanks a lot. That's very valuable input. Yeah,
so
Manuel?
just quickly to your question, Julia, I think this is key, and I mentioned it earlier during the slides, is that if the patient comes to a hospital and the physician immediately identified there is an ongoing infection process caused by a bacteria, not by a viral bacteria, and if a strong indication that this is the cause, then the patient must be treated immediately, right? They can't wait for the results. But the ideal is that you collect the sample before you initiate the antibiotic treatment. That always doesn't happen, by the way, because I have spoken to so many hospitals during my assessment, and that doesn't happen always. The lab always complains, oh, the patient already initiated antibiotic. Obviously, if you initiate antibiotic, when you do the testing, you could get false negative results. In other words, you could have a bacteria that is already inhibited, but sometimes they have to initiate the treatment. So the ideal situation is, Julia, Josefina Rodriguez, I know you're on the same page on this with your physicians as well, is that you want to take that sample before you initiate the treatment. And then while you are doing the test, while you are taking the sample and sending to the lab, then now go ahead and do the antibiotics that you feel that is more appropriate based on your historical data. And this is where this chart that Julia was showing, I was showing at the end, where they have a historical data of which bacteria are resistant, the resistance of the bacteria, the sensitivity as well, and then what possible bacteria is causing that anomaly or that condition. Then now you get the testing done. The patient is already taking the antibiotic. Now the results come back. And luckily, the results come back with the sensitivity for that particular antibiotic that the patient received. If it's not the case, then the physician will then switch to the new antibiotic properly. That's the best way to do it. It doesn't happen always.
Thanks a lot, Manuel. So I think we have to pause here. Let me remind you once again about the survey on exit. Please fill in your emails and, your name, the way you want to see it on the certificate. Don't forget about it. And then you will get it by the end of January. Thanks a lot to our speakers today, to Julia, to Jose Luis, to Manuel. I hope you enjoyed this discussion. I hope you were inspired by the examples provided by our medical facilities today, and you will start your antibiotic stewardship program. If you don't have it yet, start it very soon. Thanks a lot, and hope to see you again in our series of webinars, and we will send invitation to the next one and announce the topic. Of course, you will receive an email. Thanks a lot.
Okay, Julia.
Bye.
Julia,
Yes, Natasha.
let me just provide brief instructions. When you click on the leave button, you will be prompted to the survey on exit. This is where you put your email and where you put your name the way you want it to appear on the certificate. So not in the chat, but upon clicking leave, you will be taken to survey on exit. If there's any problems, please email us, okay? And we will verify your attendance and then prepare the certificate for you, okay? So don't worry, but try to do it. Thank you.
Bye. Thank you all.
Bye. Thank you.